Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Edelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board-certified pediatrician, and international board-certified lactation consultant. I care for breastfeeding dyads in private practice in the outpatient setting.
Hi, Lena, how are you?
I'm doing well today, Anne. How are you doing today?
Good, good. I'm excited to talk about some interesting topics. I'll start, and I want to talk about colic. This article is actually in press through BMC Pediatrics, and the title is Exclusive Breastfeeding and Infant Colic, a Systematic Review and Meta-Analysis. And the first author is Doan, and of course, many other authors. And this was accepted on July 6th. So again, still in press. So the authors performed this systematic review and meta-analysis, meaning that they pooled some of the data together to evaluate whether exclusive breastfeeding is associated with lower odds of infant colic. So according to this manuscript, 17 to 25% of otherwise healthy infants have colic in the first 6 weeks of life, which I think, as primary care physicians, that's probably right? There's a lot of babies who have colic. And
Yes.
at the beginning of the article, they said, well, we do define colic as excessive crying without an apparent cause, according to either the Wessel criteria or the Rome 4 criteria, which is a more recent sort of roundtable, set of criteria for colic. There are a lot of theories about the cause of colic, which include things like gastrointestinal immaturity, neurodevelopmental dysregulation, gut microbiota dysbiosis, and then some theories that neonatal antibiotic exposure, as well as C-section birth and family history of colic might play a role as well. There is also a theory that breastfeeding may reduce the risk of infant colic because of the opportunity to develop a healthy gut microbiome. And the reason why that's important is because we know that bacteria in our gut play an important role in further metabolism of things that we eat, secreting various factors that can play a role in other parts of our body, like our brain health specifically, through the gut-brain axis. So the thought is that there's breast milk modulation of that microbiome, and also some of the immune regulation may play a role in the gut-brain axis. So again, this is like, looking at a whole bunch of studies. And so in their inclusion criteria, exclusive breastfeeding was defined as either direct breastfeeding or feeding expressed breast milk. So they only took studies that defined where there was a definition of exclusive breastfeeding, and there had to be in this study a comparison group that either would be mixed feeding or formula feeding. Or in some studies, they called it they either said they were exclusive breastfeeding or non-exclusive breastfeeding, meaning that they put together formula feeding and mixed feeding all in the same bag.
Wait, so can you just clarify for a second? Was exclusive breastfeeding including breast milk fed, but by means other than feeding directly at the breast?
It could be either, yeah, the exclusive breastfeeding in the studies that they included were not specifically at the breastfeeding, right? Like it could be expressed breast milk as well, but they were just getting breast milk. So the non-exclusive the babies that were in non-exclusive breastfeeding categories, they could include breast milk with other foods or liquids, either formula or non-human milk. So the studies were really quite varied. And the way that they collected the information on feeding practices were quite varied. So some studies assessed the families through maternal interviews. They looked at clinical records, or there was parent recall up to like 12 months postpartum. So lots of different ways. And in some studies, it was just basically a checklist where the mother or the parent said, check to colic without actually like interviewing them to find out, are you sure your baby has colic, or how do you define colic? So that's of concern. So
Self-diagnoses.
yeah, it's kind of like a foreshadow of what we're going to talk about. So seven of the 15, so I'm going to talk a little bit more about this inclusion criteria. So 7 of the 15 studies define colic as crying for 3 or more hours per day on at least 3 days. And then 3 studies assessed colic using maternal responses to questions that describe typical symptoms such as severe crying or recurrent episodes of unexplained crying or irritability. Now, you and I both know that that can also be due to like food protein sensitivity, or it could be due to reflux or something in their eye or hair around their toe or something like that. And then in 3 other studies, colic was included as an infant health condition that mothers could identify from a list, but again, there was no definition. And then 1 study used an infant colic severity questionnaire, and another study identified colic based on whether the parent sought healthcare for their infant symptoms. So that's like just this broad, like, oh, your baby's crying, you went to the doctor. Okay, your baby probably had colic. So some concerns, of course, about the way that these studies were collected or made the diagnosis of colic. So they reviewed 13,000 articles that were published between 1966 and 2026, and they identified 15 studies that included about 215,000 infants. And so they put the data together to make a meta-analysis. And the bottom line is that they found that exclusively breastfed infants had a 19% lower odds of colic than non-exclusively breastfed infants. So again, they compared exclusively breastfed to non-exclusively breastfed. But when they actually did like a subgroup analysis and they looked at those that were defined as completely formula fed, they didn't see a difference in those that were exclusively breastfed. So the formula fed group was specifically like just getting formula. The non-exclusively breastfed group could have had formula, some breast milk, some cow's milk, some, gripe water, like, whatever it was. So then they looked at dates of the studies. And because again, these studies went from like 1966 and 2026. And when they divided the studies between dates, they found that 6 studies that were done before 1990 didn't have any significant difference with exclusive breastfeeding and colic. So they didn't really even see it. But then among 9 studies after 1990, there was a very significant relationship between exclusive breastfeeding and decreased odds of colic, with a 32% decreased likelihood of colic. So I think the 19%, the 19% lower odds of colic that they summarize in the meta-analysis includes those earlier studies, so it kind of waters it down. But if you just look at the studies after 1990, it's a really significant, like cuts it down by a third to be exclusively breastfed.
So interesting, because it's not like babies magically changed after 1990. It had to have been a difference with how the studies were done or some different criteria.
Yeah, exactly. So unless, there's like a major change in formula or something like that, but the authors didn't really have a substantial theory for why colic rates would be lower when you're comparing exclusive breastfeeding to mixed feeding versus, no difference when you compare exclusive breastfeeding to formula feeding. But then I looked, they like listed all their studies and how the data was collected, what the criteria were. And they have in this table, they have them in order of date. And when I look at that, the studies that were done before 1990 tended to define colic as unexplained periods of crying, or the mother identifying colic in this list of health issues and just like checking colic. And those were the same studies that actually had a specific formula feeding group. And the later studies, like after 2000, they had much more strict criteria for colic. And in those studies, the majority of the comparison groups were they didn't have like formula fed groups, right? Because 100% formula feeding babies, we don't see that many of them, right? I mean, certainly since 2000 and of late, about 85% of families are initiating breastfeeding. And so it's much more likely that that they're going to end up in a non-exclusive breastfeeding category than in a 100% formula feeding category.
I
So
agree.
really so it probably would be cleaner to in the future, like to take this data, like they obviously have a ton of data, to redo this and just do a subgroup analysis of those that only included babies in the non-exclusively breastfed group and also had a stricter criteria for colic. But it's encouraging. So I would say, like, their summary is that there's a 19% decreased risk. I would go with their subgroup analysis, which is like there's a 32% decreased risk of colic among exclusively breastfed babies. And it makes sense, right? I mean, it goes along with the we have biologic plausibility for that difference in gut microbiome, and it does seem to be that that there's there's strong evidence for gut microbiome to be associated with colic, and there's such a difference in gut microbiome. So yeah, and also the other thing that I find super interesting, which kind of, adds to this theory, is that when you give Lactobacillus reuteri to babies for colic, that's like the best medicine, so to speak, like the most evidence for therapy for colic, but it only works for breastfed babies because um, babies who are breastfed are given the oligosaccharides, which is like the correct fertilizer for Lactobacillus reuteri. Formula doesn't have what it takes to support the growth and development of the Lactobacillus reuteri in the gut. And so that's why babies who are breastfed, like, they just respond so well to Lactobacillus reuteri. People will tell me, like, wow, that made a big difference. It usually takes like a week. But in those who are mixed fed or formula fed, like, it doesn't really do anything. So
Yeah, actually, and I have a question. Clinically, when you are caring for patients where the babies are being mixed fed, and if they are having colicky symptoms, and uh, if you counsel these families to start giving their baby a probiotic, do you think it would make a difference if they gave the probiotic with a feed that was breast milk as opposed to giving the probiotic with a feed that included formula? Like, do you think that that
I
could
don't
still
think
be of use?
I mean, I don't know, because I mean the bacteria is going to hang around for a while and then it's just going to die off if they don't continue to get fed those oligosaccharides, the healthy oligosaccharides, the ones that they need specifically.
Yeah.
So yeah. So I don't, unless the formula companies come up with a formula that's specifically like colic formula with the right oligosaccharides that Lactobacillus reuteri wants. But then again, we don't even know if that's going to work, right? Because it's like the whole orchestra of the gut microbiome. It's not just about like the trombone player or the violin, player. It's not the first chair violin. It's like the whole everything, the whole band, the whole orchestra. So yeah. But yeah, I don't think it matters because you just need that consistent, food for the healthy bacteria.
Well, thank you for sharing that article.
Yeah, yeah. So we're going to move on and talk about what is your topic?
Oh, so I am going to be talking about an article that was published this past month in Breastfeeding Medicine called Relactation Success, a randomized controlled trial of health promotion model-based education and follow-up. And the authors of this article are Daştan Yilmaz and Yeşilçiçek Çalik. So we know that relactation is possible. It can be challenging, but it's possible. But there's very little high quality research evaluating the best way to support families through that process of relactation. So this article is a randomized controlled trial that helps to address that. The investigators evaluated whether a structured relactation program with education, individualized counseling, and ongoing follow-up improved relactation success compared with routine lactation care. So the study was designed as a prospective, single-blind, parallel group, randomized controlled trial using a computer random number generator. And it was single-blinded in the sense that participants did not know which group they were in, but due to the nature of the study, the researcher was not blinded. And to mitigate for the potential for observer bias, the researcher employed standardized measurement tools, and all of the data was coded for analysis purposes. So before I talk more about the intervention, let's talk about relactation and how that is defined. So they defined relactation as the reestablishment of milk production after breastfeeding has decreased or ceased for a period of time. So in short, the authors considered relactation to be occurring in situations where mothers did not breastfeed despite having no medical contraindications to breastfeeding. And those who decreased milk production and had been supplementing with formula for at least 2 weeks. And after the introduction of formula, it led to them self-reporting a noticeable decline in their milk production. So I wanted to highlight this definition because it is vague, it's broad, and 2 weeks of additional formula supplementation does not sound like a significantly long period of time, but milk production can drop quite rapidly in that amount of time if there is limited nipple stimulation and effective milk removal. And a common pattern that I see in my clinical practice is moms reporting fatigue and needing to rest following delivery, hence the early introduction of formula. And then our paths cross when they are maybe 3 or 4 weeks postpartum, and the baby at that point is refusing the breast, and the mothers may be pumping like twice a day or so with very low volumes expressed. Is that a similar pattern that you see in your practice at times?
Sometimes I would say that, whatever led to that drop in production, a lot of times they're seeing me at a point where they have second thoughts, where they realize, oh, like, where was my brain when this happened? And I want that milk back. And sometimes they haven't lactated for like 3 or 4 weeks. I just want to interject that, relactation is very nuanced, and that, when we look at like the histologic research, that really within 8 days of no milk removal, there's in many women, there's like apoptosis. There's a rapid taking down of the cells. But then there are some women who, like, it doesn't happen to them. And so the question is, is it age related or what? So I'm really interested to hear, what, if there's any kind of description of like, learn about the intervention you're going to describe, but also like, okay, who was successful and who wasn't? So.
Yeah, great questions. So back to the intervention that was being used. The study aimed to evaluate the effect of education and follow-up based on Pender's health promotion model, which is a model introduced by a nurse, Nola Pender. So the health promotion model is a behavioral framework designed to help explain why people adopt healthy behaviors. So rather than simply telling people what to do, it focuses on building confidence, addressing barriers, strengthening their support systems, and helping patients develop realistic plans they could actually carry out. So it's very much like motivational interviewing. It's very key to patient-centric care. Mm-hmm. So you're asking, who were these patients?
Yeah.
So this study enrolled 73 first-time mothers whose infants were between about 2 weeks of age and 4 months old. The mothers were between 19 and 45 years of age, and they had either completely stopped breastfeeding or experienced a markedly decrease in milk production, and they had been relying on formula from anywhere between 2 to 8 weeks. So very importantly, mothers using pharmacological galactagogues were excluded. So this study was really just focusing on the impact of behavioral and lactation support rather than medications. And like typically we would be using metoclopramide here in the US or domperidone elsewhere in the world.
Or domperidone here in the U.S.
Or domperidone here in the U.S. Not prescribed, but education on its mechanism of action and how it is safely dosed in other countries. So, what was different about the intervention? So, the intervention combined several evidence based practices into a highly structured program over 8 weeks. These mothers received individualized lactation counseling, a written education booklet, weekly follow up, online messaging and video support when needed, repeated assessments, and also like just practical coaching on breastfeeding techniques. And depending on each dyad's needs, counseling may have included familiar relactation strategies such as incorporation of more skin to skin care, breast stimulation, pumping, the use of at the breast supplementers, and gradual reduction of formula as their milk production was increasing. So that was in the intervention group. In the control group, many of the same relactation techniques were also available, but they received routine care, I'm saying that in quotes, through a lactation clinic. So they had access to lactation care, but it was out a structured, proactive follow-up in the structure of this health promotion model. So the difference was the individualized behavior planning, scheduled weekly follow-ups, and really proactive ongoing coaching.
Mm-hmm.
So what was assessed? Breastfeeding self-efficacy forms, breastfeeding motivation scales, the Latch tool, and IMDAT, which was a tool that I was not as familiar with, infant breast milk intake scoring system, where it uses markers to indicate sufficient infant nutrition. The authors also assessed the extent of relactation, where it was complete relactation, partial relactation, or unsuccessful relactation, and milk production. Mm-hmm. So what happens? After 8 weeks, nearly 66% of mothers in the intervention group with this proactive coaching and support achieved exclusive relactation, compared to 8.5% in the routine care group.
Wow, that's huge.
Right? Like that is very notable. If we look at the partial relactation, so they felt like their milk production increased, but they were still mixed feeding their babies. Another 21% achieved partial relactation in the intervention group, and a higher percentage in the control group, 45% achieving partial relactation. So that means nearly 80% of mothers receiving this structured support were able to successfully resume at least some breastfeeding, as compared to about 55% in the control group. Yeah. So you were asking about who these mothers were and like what the background was. On further analysis, despite the random number randomization, there were some differences between the two groups, specifically the elapsed time since the most recent breastfeeding episode, and the baseline milk volumes. Yeah. So in the intervention group, the elapsed time since the most recent breastfeeding episode was an average of about 14 days, but then it was like a broad range, plus minus 16 days. So even before the baby was born, versus the control group, it was a 30-day average, plus minus 15 days. And the other difference being the baseline milk volume, where baseline milk volume was also a little bit lower in the control group, but much closer to the milk volume in the intervention group. So after adjusting for the differences between the groups, though, including like the differences in the time since the most recent breastfeeding episode and the milk production at the time of initiation, mothers in the intervention group were still 13 times as more likely to achieve complete relactation. So the odds ratio was 13 and change, which suggests that the benefit wasn't simply due to starting with slightly more milk or stopping breastfeeding more recently. Like that's a really significant odds ratio to have a 13 times more likely that you are going to achieve complete relactation. So that is the percentages of relactation. Now looking at milk production. Average expressed milk volume increased from roughly 20 milliliters at baseline to almost 100 milliliters in the intervention group. So how were they defining this like expressed milk volume?
Is that volume per expression or per day?
Same double electric pump provided with flanges by the authors and standardized to 20 minutes of expression time. So a single pumping session.
Okay.
So the control group improved much less. They averaged only about 20 milliliters per pumping session at the end of the study. So a difference of 100 milliliters to 20 milliliters. So also importantly, to point out, there were no intervention-related adverse events, including mastitis, reported clogging, or any infant complications that were reported during the study. So another clinically interesting finding is that mothers developed much greater breastfeeding confidence in the intervention group. Their breastfeeding self-efficacy scores increased significantly over the study, and the intervention group demonstrated better breastfeeding techniques as measured by latch scores and better measures of infant milk transfer as measured by that IMDAT scoring system. The breastfeeding motivation itself wasn't dramatically different between the groups. And this suggests that many of the mothers were already highly motivated to breastfeed. So it wasn't the motivation itself that was lacking, but perhaps the structured support and ongoing coaching over that 8-week period of time that really made a big difference. So what should we be taking away from this article? So the intervention, it bundled together a whole bunch of things that we already know are helpful. So frequent follow-up, individualized care, the hands-on assistance, and the incorporation of some of those other techniques that we already mentioned. And the study reinforces that relactation is a process. And the study suggests that frequent follow-up, ongoing troubleshooting, and repeated encouragement may be just as important as the techniques of relactation itself. So limitations to the study, it is relatively small. It ended up being only 73 mothers total, 38 in the intervention group, 35 in the control group. It was conducted at a single center. And the follow-up only lasted 8 weeks. So we really don't know the extent of how long this relactation success went on for, and if once the intensive structural support went away, if these families were able to maintain lactation. And so bottom line, I mean, it makes me feel a lot better about encouraging my mothers to follow up weekly when we're trying to help them relactate. Sometimes I worry that I'm asking too much of already exhausted families to be coming into the office so frequently. But this trials really suggest that the frequent follow-ups may not be an added burden, but it might be one of the things that's most important in helping them be successful with relactation, having that proactive follow-up there in place instead of more of a reactive, come to me if you still need more assistance.
Yeah. Well, I think a couple things. One is that I'd be really curious to know what percentage of these women were under 25, because I find that relactation is so much easier when people are young. And so I think what I find in my practice, I don't see this degree of relactation. Like the majority of people who come to me for relactation, they work so hard and they just don't get very far. But they're older. A lot of these women are over 30. And I find that a lot of people who are really young, they just go back to breastfeeding. They don't even come in to be seen. They're like, yeah, I didn't breastfeed for a couple of weeks. I decided to put my baby back to the breast. Now my baby's doing fine. And I'll hear these stories from young women, and our body's
Yeah.
made to make milk early. So I feel like in some ways, and things in Turkey may be different, right? But I find in here, young women just find their resources through social media and they just put their babies back to the breast. And we're getting the people who really struggle, who are older, maybe have some comorbidities. Um, and so,
Yes, they
yeah,
didn't tease that out so much. I will say that the average age for these women
uh,
were 28, 29 years old. So they weren't super young. The study did include a broad variety, but they did not do that subgroup analysis to divide it up by age to see where the successes were.
yeah, because even with an average, if most were like 19 to 24, but then you had like two who are 45, that average becomes
Could
28. But
skew it.
where are they? What's the median, right? So there's that. I would look at it more carefully because it's just from my experience. Again, relactation is just really hard. The other thing is that, in the last case discussion that we did about oxytocin nasal spray, we sort of did a little deep dive into oxytocin and realizing that oxytocin does play a really important role in raising prolactin, which I never realized as much before. And so, what may be different about this group as opposed to what I see happening with my patients who come to me to relactate, my patients are really depending on a pump oftentimes, but not spending the time skin to skin. And when you look at some of the older studies on relactation, like from like the 1980s and 90s, there was a lot of time spent like baby skin to skin, skin to skin. And you mentioned this too in the study from Turkey, lots of skin to skin and having at the breast supplementer. And I think that all that just flooding of oxytocin is probably really helpful to raise that prolactin too. It would be nice to know like I would love to see some studies on skin to skin versus not skin to skin and how much of a rise they get in prolactin after nursing. That would be super interesting. Um, but versus pumping. So I think, I think we go about it the wrong way. And I think for someone who's like a busy professional who wants to get their milk back, who wants to be on the go, even if they're not working outside the home, to get them to like hang skin to skin, it's like they're not, I don't know. It just seems like my American population won't do that. I don't know about yours, but
No, I agree. I agree. And I want to go out. We have to go to do things. We have to be out and about. Or if there's a toddler at home and they want to be paying attention to another child, and it's hard to just be in a chair holding a baby,
right,
not doing anything.
right.
There's
But
challenges.
right, right. But when you think about that, like in other countries, there's multi-generational homes, right? So the grandparents are there taking care of the older kids, the mom's taking care of the baby. There's lots more like holding and not sitting in a car seat. And when you look at some of these older studies on relactation, like the World Health Organization, their last sort of like booklet that they wrote on relactation was from like 1999 or 1990 or something. And it talks all about like pretty much the things that you're talking about with the study in Turkey, where there's just a lot of encouragement and skin to skin and keeping the baby at the breast and having the baby suckle many times a day. And obviously, in many cultures, that has to have been successful. And when you look at, for example, there's this, there are reports from a culture, I think it's Zulu culture in Africa, where the grandmothers relactate because the grandmothers are suckling the babies while moms are at work because they don't have
Hmm.
pacifiers and the baby's crying and they put the baby to the breast and the grandmothers, if they're premenopausal, they're, relactating, bringing their milk back. And so it's just, just different cultures. So I think culture, behavior does play, like as you're really saying in the study, does play a really important role in relactation. And to think that we can translate that to like, okay, pump more often, do some heart pumping, it just doesn't seem to work as well, especially in older women. So yeah, apples
Yeah.
and oranges, apples and marshmallows. Yeah. Yeah. Well, thanks for sharing that. That's really interesting. So, yeah. All
All
right.
right. I'll see you next month.
Yeah. See you later, Lena. Bye.
Bye.
Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org, so come check us out and become a member to join our community.